So this is musculoskeletal, and this is beginning week 7 for us. So we are going to start with chapter 38, structure and function of the musculoskeletal system. So the musculoskeletal system gives structure and functions of the bone, gives form to the body, supports tissue, permits movement by providing points of the attachment for the muscles. Sorry guys. Protects many vital organs, serves as a site for blood and cell formation, and it plays a role in mineral storage. It stores minerals such as calcium, phosphate, carbonate, magnesium. It plays a role in hormone homeostasis and assists in maintaining and normalizing immunological function, and there are 206 bones. So mature bone is a rigid connective tissue consisting of cells, fibers, a gelatinous material termed ground substance, and a large amount of crystallized calcium salts. These make the rigid bones. This makes the bones rigid. They block oxygen and food diffusion, so bones must contain vessels. The types of bones are distinguished by the pattern the crystals are laid in. So, calcaneous bones is a lattice of teeny struts of bones like a sponge. Compact bones lay down in layers like an onion. Bone cells enable bone to grow, repair, change shape, synthesize new bone tissues, and reabsorb old tissue. The bone matrix consists of ground substances, collagens, and other proteins that take part in bone formation and maintenance. Calcification, in which the materials are deposited and then crystallized. And then there's bone cells. There's osteoblasts that lay down the extracellular matrix. Osteoclasts break down the extracellular matrix. Osteocytes live in the matrix in the mature bone and maintain the extracellular matrix. So in this first one, we're seeing a magnified view of compact bone. The next picture shows a longitudinal section of a long bone showing both callous and compact bone, and a section of flat bone. So several hormones influence bone structure. Growth hormone is good for normal bone growth. PTH is released when blood calcium levels decrease. Sustained PTH raises blood calcium levels 3 ways: from bones, kidneys, and intestines. Vitamin D is needed to absorb dietary calcium. It controls reabsorption of the calcium and the phosphate by the kidneys. It's fat soluble, and it is created in the skin cells under the influence of sunlight. And where we live, the majority of people are low in vitamin D, and we do check those levels. If somebody is under 30, then they go on 50,000 IUs of vitamin D once a week. For bone health, you really want that number close to 60 or 60 should be their blood level for vitamin D. Calcitonin is released by the thyroid when calcium is too high. It inhibits calcium release from the bone, and it inhibits vitamin D activation in the kidney. It inhibits calcium reabsorption by the kidney. Vitamin K also increases bone calcification and reduces serum osteocalcin. Okay, so the compact cortical bone makes up 85% of the skeleton. It's highly organized, solid, and extremely strong. It's part of the Haversian system. So the centralized canal is called the Haversian canal. It's concentric layers of bone matrix called lamellae. Its teeny spaces of lacunae between the lamellae and bone cells, osteocytes, are within the lacunae. The small canals, or the canals called canucilii, all make up that canal. So then we go to the spongy canal, the spongy bone. It's less complex. The lamellae are not in concentric layers, in the plates or bars are termed tubulicae, and that branch and unite to form irregular meshwork. They make up 15% of the skeleton. They lack the Haversian system that's very complex. And then they just make into the, and then obviously, like we talked about, the trabinulae. The periosteum is the outer layer that contains the blood vessels and the nerves, some of which are penetrate to the inner structures of the bones through the canals called Volkmann canals. There are 206 bones in the human skeleton. The axial skeleton make up 80 bones. That includes the skull, the vertebral column, and the thorax. The pendicular skeleton makes up 126 bones. It's the upper and lower extremities, the shoulder girth, and the pelvic girth. So now we have the long bones. And when we're talking about the long bones, we start with the epiphyses and the epiphyseal plate, okay? And then we go to the diaphyses, or the shaft. They are longer than they are wide, okay? They contain the bone marrow and yellow marrow fatty tissue. Then we're going to talk about, then we go to the epiphyses and the epiphyseal plate on the other end. But if you think about it, they actually have some of the red marrow, and they call them that because it's the blood-forming marrow. So it's the blood-forming tissue. So if you think about it, it's really up at that end of the bone. And the only time the yellow marrow will help form blood is in times of stress. Then we have the flat bones, which is the ribs and the scapulae, and there's a spongy bone between them, like a spongy layer of bone between them. And then there's the short bones, such as the ones of the wrists and the ankle, and they are called cuboidal bones. And then we have our irregular bones. Those are the vertebra, the mandibles, and the facial bones. So remodeling, our basic multicellular units, repair the microscopic bone injuries, maintains bone integrity. And actually it happens in like 3 different phases. So what we're going to talk about is the basic multicellular units carry out remodeling. Osteoclasts and osteoblasts. Okay, then there's the activation of the remodeling cycle. It's a stimulus hormone, activates the cytokinase system, particularly the numeral necrosing factors superfamily. And that's going to ask for the osteoclasts. And then the osteoclasts are going to connect to the bone matrix. They start to digest the bone. The degraded bone products are then put into the vascular system. After the bone is reabsorbed, the osteoclast leaves behind an elongated cavity termed a reabsorption cavity. The new bone formation begins as osteoblasts line the walls of the reabsorption cavity and express osteoid and alkaline phosphate deposits or deposition. And as the osteoid mineralizes, new bone is formed. Successive layers in compact bones are laid down until the reabsorption cavity is reduced to a narrow hallucination canal around a blood vessel. This takes about 3 to 6 months. New bone is the final result for the different stages when we're trying to get through the stages when we've had a surgery. So like remodeling process can repair microscopic bone and injuries, but gross injuries from like a fracture or surgery, it can't. And then we're going to go into the replacement by basic multicellular units of callus with lamellar or tubular bone. And what's going to happen is there's remodeling of the periosteal and the endosteal surfaces of the bone to the size and shape of the bone before injury. And what's going to happen is then they're going to get this calcus formation and calcus replacement. But this can actually take up to 4 years in some cases to complete the whole process. So when we're talking about our skeletal muscles, we're talking about millions of individual muscle fibers that contract and relax to facilitate movement. There's 75% water, 20% protein, 5% organic and inorganic compounds. There's more than 600 in the body, and they range from 2 to 60 centimeters long. The skeletal muscles connect to bone, and they are the most frequent occurring muscle types, making up 40% of the body's weight. And there are 350 muscles that are under voluntary control of the brain. Fusiform muscles are elongated muscles that they're shaped like straps. Pennate muscles are broad, flat, and slightly fan-shaped muscles. Both tendons and ligaments are primarily composed of types 2, 4, 5, and 6 collagen and fibroblasts. The fibroblasts and tendons are arranged in parallel rows. They attach muscle to bone, they transfer forces from muscle to bone, and they act as a type of biologic spring for muscles to allow additional stability during movement. The fibroblasts appear less organized than ligaments. They attach bone to bone. They stabilize joints against excessive movement. Aging in the musculoskeletal system. So bones, we have bone loss, less dense, less strong, more brittle. Bones remodeling time is lengthened. Rapid bone loss occurs around menopause. This is due to the loss of estrogen. It increases osteoclast bone reabsorption and fewer osteocytes. There's a decreased number of osteoblasts. By 70 years old, 50% have lost their peripheral cortical bone mass, and men lose theirs at a slower rate. Osteoporosis makes this more risky for us. And we have joints, our cartilage becomes more rigid, fragile, susceptible to fraying, and we have decreased range of motion. This is why one of the things I try to teach patients is to do yoga so that they keep their flexibility, which is helpful. Muscles, there's sarcopenia, which is age-related loss of muscle, of skeletal muscle, and is a direct cause of the age-related decrease in muscle strength. This starts the 5th decade and is evident by the 7th decade. The decrease in muscle mass and strength is apparent by then. It reduces oxygen intake, basal metabolic rate, and lean body mass. Chapter 39, Alterations of Musculoskeletal Function. So bone fractures. Bone fracture is a break in the continuity of the bone. A fracture can cause damage to the bones, joints, muscles, tendons, surrounding tissues, blood vessels, and the cortex and the marrow. When a bone breaks, blood from the damaged vessels in the periosteum and bone marrow pours into the fracture and forms a hematoma. Bone tissue destruction triggers an inflammatory response, and procalcus formation is after calcium is deposited into the calcaneus joint ends. Some bone fracture calcifications. We have a transverse fracture is a fracture straight across the bone shaft. Oblique fracture is a fracture at the angle towards the end of the bone shaft. An occult fracture is hidden fracture and not discernible. A spiral fracture is a fracture that twists around the bone shaft. A comminuted fracture is a fracture characterized by multiple fracture lines and bone pieces. Pathologic results from a weakness in a bone structure, secondary to a condition such as bone tumors or osteoporosis. A green stick is an incomplete fracture in which the bone is bent and only the outer cure of the bend is broken. Commonly occurs in children because of minimal calcification and often heals quickly. Impacted fractures occur when one end of the bone is forced into an adjacent bone. Manifestations can include pain, tenderness, swelling, deformities, possible muscle spasms, impaired mobility. Usually we diagnose fractures by x-ray, and we're going to fix them either by close manipulation, traction, or open external fixation. We can also use internal fixation. Dislocation, subluxation. Improper reduction or immobilization, so non-union or delayed union or malunion of a fixed bone or joint can do this. A dislocation is the displacement of one or more bones in a joint, loss of contact between the articular cartilage. Clinical manifestations of a dislocated joint may include visibly out of place, discolored or deformed joint, limited movement, swelling or bruising, intense pain, especially with movement or weight bearing, paresthesia near the injury. Subluxation is contact between the articular space is only partially lost. Associated with the fractures, muscle imbalance, rheumatoid arthritis, or other forms of joint instability. So support structures. Strains is tearing or stretching. Is tearing or stretching of the muscle structures. So it's actually stretching and tearing of the muscle or the muscle tendon unit. It results from awkward muscle movement or excessive force that improperly stretched the muscle that was contracting. A sprain is a tear or injury to a ligament involving the ligaments surrounding the joint. Pain and swelling subside more slowly than in strains, and the symptoms include edema, pain at the site, bruising, limited function. Avulsion is complete separation of a tendon or a ligament. What we want to do is we want to protect these injured limb from further injury by not using that joint. We want to do RICE, which is rest the injured limb, but do not avoid all activities, exercise to the other muscles to minimize deconditioning. I is ICE for affected area as soon as possible after injury to limit swelling and continue the ice to the area for 10 to 15 minutes, usually 4 times a day for the first 48 hours. C is compress the area with an elastic wrap or bandage. E is elevate the injured limb about the level of the heart whenever possible to prevent the limb from swelling. Tendon and ligament injuries usually lack sufficient strength to withstand some stress for at least 4 to 5 weeks after the injury. They are usually painful and usually are accompanied by soft tissue swelling, changes in tendon or ligament contour, and dislocation or subluxation of the bones. Rehabilitation is crucial to regain good function and outcomes. So usually it's good to put these patients into PT. Tendinitis or bursitis. So tendinopathy is actually the proper term. It's inflammation of a tendon, pain of the tendon, or the inflammation is where it attaches to the bone. An example of this is tendon elbow, and this is from overstretching, or golfer's elbow is from both stretching and flexing, because you're getting both in that. Bursitis is inflammation of a bursa, and that's skin over bone, skin over muscle and tendon over bone. The inflammation is usually caused from overuse or extensive pressure. And bursitis is usually reactive to overuse. And the inflamed bursal sac becomes engorged, and the inflammation can spread to adjacent tissues. We usually say rest, ice, and aspiration of the fluid. It only is limited by pain. Usually it's clinical history that we're going to figure this out, occasionally ultrasound or MRI. They will do a local injection of, usually we'll use like Kenalog and Marcaine to get inflammation down if it's not responding to like PT and rest and such. Septic bursitis is caused usually by a wound infection. Complications from musculoskeletal injuries. Compartment syndrome is a serious condition that results from increased pressure in the compartment, usually the muscle fascia in the case of fractures. Compartmental syndrome, the pressure impinges on the nerves and the blood vessels presented within the compartment, potentially compromising the distal extremity. Symptoms include excruciating pain or beyond what would be expected. Given the injury, measure the pressure of the muscle fascia, and treatment is immediate fasciotomy to relieve the pressure. Fat embolism occurs when fat has the opportunity to enter the bloodstream. It's usually after a fracture to one of the long bones. Outcome can be fatal if it travels to vital organs such as the brain or the heart or lungs. Osteomyelitis refers to an infection of the bone tissue. This is a serious complication, goes undetected, and can take months to resolve. Osteonecrosis is avascular necrosis is death of bone tissue due to a loss of the blood supply to that tissue. It can result from displaced fractures or dislocations. Surgical replacement of the necrotic bone or joint usually needs to take place. Osteoporosis is generally described as decreased bone mineral density. It's increased risk of fractures due to alterations in bone microarchitecture. It's associated with pathogenic mechanisms that decreased osteoblast activity or increased osteoclast activity. The decline in bone mass occurs with advanced age, decreased estrogen or testosterone, or decreased activity. Excess intake of caffeine, phosphorus, alcohol, or nicotine, inadequate levels of vitamin D and C or magnesium. It's considered a silent disorder. Many times we don't catch it until there's a fracture or a Dowager hump, and diagnosis is usually from a BMD testing or DEXA scan. There are actually different types of osteoporosis. There is iatrogenic osteoporosis, which is caused usually by medical treatments, and it's usually due to the medication. There's regional osteoporosis, which is disuse of an immobilized limb. This usually is due to weightlessness on that limb, and it can get osteoporosis within 8 weeks. There's postmenopausal osteoporosis. That's usually due to low estrogen levels, and that usually happens around menopause. There is glucocorticoid-induced osteoporosis. Corticoids improve osteoclast survival, which inhibits osteoblast formation and function. It's usually secondary to prednisone or cortisone use. And then there's age-related bone loss, and that's cause is unclear. They do think that's related to physical activity is likely a factor. It usually starts the 3rd or 4th decade. It decreases serum growth hormone and insulin-like growth hormone, and it increased binding rank E1 and decreased LPG production and affects osteoblast and osteoclast function. So, osteomyelitis. Osteomyelitis is an infection of the bone. The bone infection is often caused by a bacteria. It's usually Staphylococcus aureus. If it's an open wound, we call it exogenous, and that's the most common. If it's a blood-borne infection, it's endogenous. It's manifested by inflammation. It could be acute or chronic, fever, pain, malaise, anorexia, weight loss, and pain in and around the infected areas. They have exudate inside the bone, damage to the arteries in the bone, and can penetrate skin and involve joints. Biggest thing is we want to it's contamination from the skin lesions. Chronic osteomyelitis usually is in adults, generally due to an open wound. The sequestrium is a hallmark sign, which is presence of an infected dead bone. And when they open it up, they will actually see it's been pulled away from healthy bone. Treatment includes antibiotics, debridement surgery, hyperbaric oxygen therapy. Osteoarthritis is a non-inflammatory joint disease. It's degenerative joint disease and loss of articulating cartilage and overlying bone, as well as the bony overgrowth, which you will see on usually around their knuckle area. Degenerative joint disease is its other name. It increases with age and unfortunately is more prominent in women for us ladies. It's primarily a disease is idiopathic. Osteoarthritis risk factors include increased age, joint trauma, long-term mechanical stress, drugs, endocrine disorders, and obesity. Osteoarthritis characteristics include loss and damage of articular cartilage, inflammation, new bone formation of joints, muscles, subchondral subchondral bone changes, variable degrees of mild synovitis, and thickening of the joint capsules. I didn't mention this on the last slide, but endocrine disorders include hyperparathyroidism. Characteristics include local areas of damage and loss of articular cartilage, new bone formation of joint margins, subchondral bone changes, variable degrees of mild synovitis, and thickening of the joint capsule. Manifestations include joint pain that is exacerbated during or after movements or weight bearing, joint tenderness with light pressure, pain worsens with activities, enlarged joint, hard joints, joint swelling, limited joint range of motion, crepitus, hard nodules around the affected joint, and bone spurs. Disease onset is gradual, usually begins after the age of 40, and joint deformities. Usually treatment's conservative, meaning exercise and weight loss. Pharmaceutical therapies include analgesics and anti-inflammatories, and some will do like nutritional supplements like costochondroitin. Also, the tart cherry juice people mentioned they get a lot of benefit out of. Surgical treatments used to improve joint movement, correct the deformity, malalignment, or create a new joint with artificial implants. Rheumatoid arthritis, inflammatory autoimmune joint disease. Women more than men, peaks around the ages of 40 to 50. Systemic autoimmune damage to connective tissues, primarily in the joints and synovial membrane. Auto antibodies against gamma-globulin will be present, rheumatoid factor. Similar symptoms to osteoarthritis. Causes unknown, multifactorial with strong genetic predisposition. They'll have systemic manifestations of fatigue, weakness, generalized aching, and stiffness. They tend to be worse when they get up in the morning and tend to improve as the day goes. They'll have exacerbations and remissions. Usually we're going to get this diagnosed from their history, from labs, synovial fluid analysis, and radiology. We usually treat this by reducing pain, minimize stiffness, and they will do anything from gold shots, and sometimes even surgery to replace joints if it's too bad. There are actual guidelines for rheumatoid arthritis evaluation. 4 or more of the following have to be present. Morning stiffness, joint stiffness lasting at least an hour, arthritis of 3 or more joint areas, arthritis of the hand joints, symmetric arthritis, rheumatoid nodules, abnormal amounts of serum rheumatoid factor, and radiographic changes. Gout is a syndrome caused by either overproduction or underproduction of uric acid. It manifests high levels of uric acid in the blood and other body fluids. It occurs when uric acid concentrations increase to be high enough levels to crystallize. Crystal deposits in connective tissues. Metatarsopharyngeal joint of the big toe is the presenting joint for 50%. Other sites include heel, ankle, instep of the foot, knee, wrist, or elbow. 1,000 more 1,000 times more likely to develop renal stones than the general population. And gouty arthritis is when the crystals occur in the synovial fluid and cause inflammation. So mechanisms for crystal deposition. Monosodium urate precipitates the periphery of the body, where lower body temperatures may reduce the solubility of the monosodium urate. Albumin or try saying that many times. Glycosaminoglycan levels decrease, which cause decreased urate solubility. There's changes in the ion concentration, decreases of the pH, enhance urate deposition. Trauma promotes urate crystal precipitation. Risk factors include male sex, increase in age, high intake of alcohol, red meat, and fructose, and certain medications. Manifestations include an increase in serum urate concentration, hyperuricemia, recent attacks of the monoarticular arthritis, inflammation of a single joint, depositions of monosodium urate monohydrate, tophi in and around the joints, renal disease involving glomerular, tubular, and interstitial tissues and blood vessels, and formation of renal stones. Manifestations of an acute gouty attack is severe pain, especially at night. They get a hot, red, tender joint. They have signs of systemic inflammation, increased sedimentation rate, fever, and leukocytosis. So bone tumors are malignant and occur as secondary tumors from other cancers, such as breast, lung, and prostate. Paget's disease increases risk for developing primary bone cancer. They may originate from bone cells, cartilage, fibrous tissues, marrow, and vascular tissue. Osteogenic bone-forming tumors are characterized by the formation of bone or osteoid tissue with a sarcomatous tissue. Sarcomatous tissue. Sorry about that. The tissues can have the appearance of a callus or compact or spongy bone. Chondrogenic produced from cartilage or chondroid, a primitive cartilage or cartilage-like substance. Collagenetic, it originates from the mesenchymal cells and produce fibrous connective tissues. Fibrosarcoma represent 4% of the primary bone tumors. Myelogenetic are ones that originate from various bone marrow. They're giant cell tumors, the 6 most common of the primary bone tumors. Osteosarcomas are the most common primary malignant bone tumors. They're an aggressive tumor that begins in the bone cells, usually are in the femur, tibia, or fibula, occurs most often in children or young adults. Then there's the chondrosarcoma. It's a slow-growing tumor. It begins in the cartilage cells that are found on the ends of the bones. It affects older adults. There's the myelogenic tumors, which are the giant cell tumors, like we said before, originates from the bone marrow, found at the epiphyses of the femur, tibia, radius, or humerus. It usually hits ages 10 to 70. The majority are between ages of 20 to 40. Females are more likely than males for these kind of cancers. Well, I think we're officially done with this. So hopefully we will be getting caught up. Thanks.